Okay, so we are about to start. Vishnu, are you here?
Yes.
Okay, great. So first of all, for everyone who's watching us online, we're currently here in the capital of Armenia, Yerevan, having our first study club outside of Russia. And now we have our dear guest joining us from the United States of America, from the state of Texas, San Antonio, Dr. Vishnu Raj, who is a great clinician who runs his private practice. He's an associate professor at the University of Texas. He teaches residency students, and he's as I said, a great clinician from whom I learned a ton of clinical tips and tricks, and to whom I look up in my orthodontic journey. It's my pleasure to have him here today with us, and today he'll talk on the concepts of long-term stability, which is very, very important thing, probably the most important thing, because without long-term stability, what's the meaning of everything what we do in orthodontics? So, Vishnu, the stage is yours.
I'd like to thank you, Alex, and I'd like to welcome all the members of the Moscow Orthodontic Study Club group, and thank you for hosting me. I'd like to thank both Alex and Danny for their effort, and welcome to all. So, like you folks already probably heard, the topic is going to be stability, and it's something Dr. Ditmarov and Dr. Yakub lectured on prior to this part. So the topic, or the title of the topic, is Current Concepts of Long-Term Stability. Before I begin, a couple of housekeeping items to both Alex and Danny. If you all want to have any questions, or anybody has any questions, just feel free to interrupt. And I will be glad to answer that, because otherwise it just becomes a long monologue. So with that said, let's get started. Before I begin, I'd like to declare that I don't have any financial conflicts of interest with any of the materials or techniques, and I am not a paid or unpaid consultant for any orthodontic company. I'd like to dedicate this lecture to our teachers. Obviously, there's too many to be mentioned, but these 8 are, some of the folks that have influenced me, and I'm sure influenced a lot of you. Starting with upper left-hand side, clockwise, Bill Profit with Dr. Vince Kokich, Anthony Ginelli, Vic Alexander, Lyle Johnston, Charlie Burstone, Bjorn Zackerson, and Jim Bowley. Like the saying goes, if you're able to see further, it's because we stand on the shoulders of giants, and these are the giants of our profession. And it's always very important to recognize and remember the lessons that we've learned from them. So here's a brief outline of the presentation. We're going to discuss what stability actually entails, talk about stability considerations, which we've divided into skeletal, dental, soft tissue. A couple of clinical examples, maybe more if you have time, and then we're going to wrap things up. So stability is a nebulous term in orthodontics because it can mean different things to different people. So we have to break it down into factors that are related to treatment and factors that are not related to treatment. Factors related to treatment include basically orthodontic relapse or change in tooth position due to the nature of orthodontic tooth movement. Now, there's factors unrelated to treatment that can lead to post-treatment change. Those factors include continued jaw growth, aging and maturational changes. Even if somebody has had no treatment, things can shift over time. TMJ disorders, because all of a sudden that introduces a change in the equilibrium. Aberrant habits, similar thing. Again, you can introduce a change in the equilibrium of tooth position by altering the muscular force system. So this is a wonderful editorial by a name that most of you have heard, Dr. James Vaden. Now, when it comes to stability, I want to make recognize some names. There are several names, these guys you've heard of before. There's Dr. James Vaden, Herb Clance, Lee Boise, there's Tweed, of course, Vic Alexander, Jim Bowley. So these are names of orthodontists that have long emphasized the importance of post-treatment stability. So this editorial, Dr. Vaden recognizes four aspects, the limits of the dentition. There's the anterior limit, there's a posterior limit, there's a vertical limit, and there's a lateral limit. The reason this is important is it kind of tells us what we have, how much room we have to play with in what dimension. So it kind of helps establish some boundaries or limits for where teeth can be. So let's look at some considerations. So again, you have skeletal considerations, you have dental considerations, and soft tissue considerations. We're going to look at each one of these in some detail. So, Alex, am I going too fast or are things okay?
Everything is good. You're doing great.
Awesome. So skeletal considerations, what this entails is essentially coordinating the maxillary and mandibular apical base or apical bases relative to each other in all three planes of space. So one might ask the question, why is that important? It's important, obviously, for aesthetics. So if you have a situation where somebody is class 2 mandibular deficient, what that's saying is the mandible is too far from the maxilla. Aesthetically, that doesn't look very good. You've got a retrusive profile, you've got a chin that's too far behind. So from the aesthetic perspective, it can have a significant influence. Then we're talking about the stability perspective. The reason that is influenced is because, again, if you've got the apical bases too far away from each other, so in a situation where the class 2 type malocclusion, mandible is too far behind, the mandibular incisors have to procline in order to establish adequate overjet. Now, that can obviously lead to issues with regards to stability. Another example is where you've got a narrow maxilla and an attempt is made to widen the maxilla with archwide expansion. So we know that's going to tend to relapse over time. So again, that's a apical base discrepancy that we're having to camouflage by trying to move the dentition. The last example or instance is harmonious occlusal function. So going back to the same example, if you're trying to handle a transverse discrepancy by archwide expansion, you end up creating the potential for unstable occlusion, balancing interferences because the palatal cusps are now hanging down. So these three considerations are part of the skeletal aspect as it pertains to skeletal-based relationships. Now, let's look at age-related aspects. So in children and adolescents, we know that the maxilla can be successfully widened with sutural expansion. Of course, the younger you are, the better the odds. And again, we're not talking about expanding in the primary dentition. There is no basis to support those perspectives. We're talking about the past age of 7 or 8. At that point of time, we do have the potential to suturally expand the maxilla, make it wider. We also know extraoral traction can help control the position of the maxilla. It can also help affect some differential growth. So that is the use of headgear or face mask can help control the maxillary position to an extent. But what's very important to remember is there's no non-surgical mechanism to predictably widen, elongate, or restrain the growth of the mandible. So there is no suture, patent suture that we can use to skeletally widen the mandible. You can't predictably elongate the mandible because we know with functional appliances, any increment, long-term increment is in terms of growth is only about 1 millimeter, if that. And it's certainly difficult, if not impossible, to restrain the growth of the mandible. So we're sort of limited in terms of what dimensions we can influence and to how much. So now let's talk about what happens when subjects get older. Past the age of 15 or 16, stable correction, again, stable correction is what we're talking about, frequently entails or requires the need for surgery. Now, again, there's a host of reasons surgery may be indicated, but from the stability perspective, what situations may require or should surgery be considered? Some general guidelines, again, if you have an A and B greater than 7. So you have to keep in mind an A and B greater than 7 can include a multitude of situations. Specifically, let's say there's a retrusive mandible, large A and B. A surgery may be a consideration here because the alternative would be proclining the lower incisors excessively, which obviously may not be stable, or retracting the maxillary incisors excessively, which would not be aesthetic. So an anterior open bite requiring more than a millimeter extrusion per arch. So again, if you've got a skeletal discrepancy you're trying to camouflage, extrusion of the incisors beyond a millimeter or so can tend to relapse. Posterior crossbite across several teeth. If you're trying to do this at the age of 16 or something, you're unlikely to get sutural expansion without either surgical intervention or maybe a MARPE or some sort of TAD-assisted expansion. If you try to do this just with tooth movement, you run the risk of relapse here. So obviously, SARPE would be a consideration for adults past the age of 30 or 35, but under, you could certainly consider MARPE. An impinging deep bite with decreased lower facial height. So if you got 100% overbite, you don't have vertical ramus growth remaining, and your bite is opened, arches leveled by extrusion of the molars, that may not occur because it's difficult to extrude molars in low angle subjects, but B, it may not be stable because the pterygomesenteric sling may tend to reintrude the molars and the deep bite may relapse. So if you're looking at a situation like this, again, you may want to consider surgical correction. A mandibular vertical excess with well-positioned lower incisors. So this is where you have a hold-away ratio that's aberrant, but the lower incisors are reasonably centered on the bone. So that's telling you essentially that the chin may need to be positioned. So upward forward genioplasty would be a consideration there, principally from the perspective of helping minimize the mentalis strain, because in a situation like this, the mentalis muscle is recruited and constantly pushing against the lower incisors. So now let us look at the hierarchy of surgical stability. For those of you who haven't seen this, this is from a classic article by Dr. Bill Profit. So I want you to focus on the top portion here, which talks about the most stable, which is basically moving the maxilla upward, the mandible forward, the chin in any direction. But now let's go to the last. This part is the least stable, where the mandible is set back, the maxilla is set down, and the maxilla is made wider. So we're going to explore some of these in some detail. But when it comes to surgical stability, there's a hierarchy like this slide shows, and we want to consider movements that are more stable in general, obviously, to minimize the potential for surgical relapse. So why is instability a concern in surgical cases? You could have two causes for this. You could have orthodontic causes. Some examples include where you have a pre-treatment open bite and you fail to section or segment the arch. So you may end up extruding the maxillary incisors, not intending to, but if you place a continuous wire and there's a step in the maxillary occlusal plane, all of a sudden the arch leveling has occurred at the cost of maxillary incisor extrusion, which may relapse following surgery. You could have dental expansion lead to relapse in surgical cases. So if you've got a situation where you're planning surgery, you want to minimize dental movements that can predispose to relapse. Orthopedic instability is another reason, and this can happen due to occlusal interferences, typically upper sevens in class 3 cases, lower sevens in class 2 cases, because those teeth are unopposed. So unless they're intruded and the cusps controlled adequately, during the time of surgery, you can end up with those teeth presenting interferences to the seating. So your arches may not adequately seat, and you may end up with instability during surgery. Uncoordinated intercanine width in class 3 cases, because once you try to establish a class 1 relationship, the lower intercanine width may be wider, and all of a sudden, you may have some degree of occlusal instability there. Important to adequately develop the occlusion immediately following surgery, which is one of the reasons we want to see our patients as soon as possible and start getting the teeth into occlusion. This allows for a more favorable force distribution. So what we don't want to do is load the condyles excessively or lead to issues where force systems are unbalanced. So we've got to get the occlusal forces controlled across the dentition to make sure there's increased stability. What are the surgical causes of post-surgical instability? So this is where muscle action plays a big role with when the maxilla is down fractured. What ends up happening is all of a sudden your pterygomesenteric sling is stretched, and that's going to tend to want to reassert back to its resting length. And all of a sudden the muscle action increases occlusal forces and pushes the maxilla back upwards. Now with rigid fixation, this is somewhat less of an issue. But in a situation like this, two-jaw surgery may also be another option where you can certainly reduce some of the occlusal forces.
Dr. Raj,
Actually,
can I please interrupt since you
please,
said we can?
absolutely.
Yeah. What's your opinion on how early we can start with elastics after surgery?
So what I normally recommend is it depends on when the surgeon is able to release the patient. So typically I start them within about 6 weeks or so, but our surgeons generally have them on elastics right away.
Mhm.
So
But
those elastics,
very mild in force, right?
I'm sorry?
The elastics which the surgeons place, they're very mild in force.
Yes, in general, they're very mild in force because at that point of time, they really don't want to disrupt the surgical sites.
Yeah.
So 6 weeks is a good guideline. So at that point of time,
because
you're
you're pointing this factors which may lead instability of surgical cases. So I think that, you know, sometimes starting over with elastics a little bit too early could be another factor that would cause instability. Just
absolutely, and that is a great point. That is a great point because you've got to be able to use the elastic action to move the dentition, but not disrupt the surgical sites. Right. So that's a very good aspect because at that point of time, when the bone is not fully healed and you're going to apply heavy traction, you may run the risk of disrupting the bony union. So that's very important to remember. So it comes down to, again, the surgeon, but our surgeon typically sends patients to us in about 6 weeks or so, which is why at that point in time things are already, you know, relatively stable. So that's a great point. But when they come back and you see that things are, you know, let's say less than ideal, that can be a significant concern. Let's say you have a situation where you've got a open bite that was supposed to have been fixed surgically, but now you still have a post-treatment open bite. Attempting to fix that with tooth movement can be obviously prone to some degree of relapse. The same thing with expansion when you don't have enough or it has relapsed between surgery and when they come to see you. Attempting to camouflage that can lead to some degree of relapse. So these are aspects to consider, especially when you're trying to make a decision between a expansion with a Lafort versus expansion with SARPI, you know, or MARPI, because potentially the MARPI could be a little more stable from that perspective, and the SARPI because they represent histiogenesis as opposed to an acute stretching of the palatal tissue. So those are important considerations as it pertains to some surgical causes for post-treatment instability with surgical cases. Now, let's move on to dental considerations. And again, Dr. Alex, Dr. Dittmero, please feel free to jump in anytime. We'll look at some dental factors, and again, several of these aspects may have been discussed before, so I'm going to try to speed through them to an extent. Intercanine width and arch form, we're going to look at alignment, rotational correction, arch leveling, vertical correction. We're going to look at AP correction or sagittal correction, the role of incisor position and inclination, the role of root correction, the effect of posterior interdigitation, and the importance of the quality of finishing. So let's start with intercanine width and arch form. So this is something that at this stage, I think is abundantly clear that based on multiple 20, 30 articles or more, that mandibular intercanine width tends to decrease over time. So increasing the mandibular intercanine width is an exercise in futility because that will tend to revert or reduce over time. So minimal expansion there is obviously better. Alteration of the pre-treatment arch form. Again, more relevant with the mandibular pre-treatment arch form. So if you significantly alter that, that is going to relapse as well. Lateral dental expansion of the buccal segments can be done, but in terms of stability, the question is, should it be done? Because again, those aspects are prone to relapse because of the action of the muscles of the cheek. So now let's look at alignment and rotational correction. So rotations, as we know, are notoriously unstable. So this is important to begin addressing immediately at the beginning of treatment, and important to correct or even overcorrect and hold the correction. it's important to stabilize the correction and hold it through treatment. So the longer you hold it, the better your odds are in terms of stability. So rotational correction best done with round wires. So in this particular example, you can see the wire completely deflected into the slot and steel ligated to help affect the correction of the cuspid. And it helps to slightly offset the bracket in terms of towards the rotation to help correct it or overcorrect it. And then first order bends help position the teeth to be corrected adequately. So in this particular example, you've got a little mesial outdistal and bends placed at the lower cuspids to help correct the rotations fully. And at that point in time, you can titrate the amount of correction you want. So let's talk about why this is an issue. So relapse here occurs due to stretching of the supracrestal transeptal fibers. So these stretched fibers will tend to want to return back to their original shape. So if you don't allow enough time for it to reorganize, that's obviously going to be a cause for concern. But the more important thing is to consider the degree of rotation. Let's say you've got more than a 45-degree rotation. At that point in time, you want to consider a surgical procedure. Supracrestal fibrotomies are extremely beneficial with teeth that are significantly rotated. And like in this example here, you've got a bicuspid that's almost 90 degrees rotated. So correcting the tooth will require both overcorrection of the position as well as supracrestal fibrotomy to help minimize the potential for relapse. In this case, unfortunately, it was not overcorrected. It was corrected, but you can see there's still a little bit of rotation here. It should have been rotated mesial out more, but the supracrestal fibrotomy was certainly done. This is a couple of weeks after. You can see the tissue is still not fully healed. But obviously, I would still expect some degree of relapse here because of the orthodontic failure or inability to fully overcorrect. In a case like this, you definitely want to consider overcorrecting the rotation because of their notorious tendency to change. IPR to broaden contact areas. That's another aspect, especially with lower incisors. It helps to change contact points to contact areas. Even if it's an extraction case or a non-extraction case, that helps ensure some degree of stability. Again, we're talking about a little bit of IPR. We're not, talking about entire enamel removal. But that is something that's definitely beneficial to consider. So next step in treatment is arch leveling. So arch leveling is vertical correction. It's important to level the caruspi in order to facilitate sagittal correction, space closure, and allow for optimal interdigitation of the buccal segments. So leveling, as we know, can occur by relative intrusion, where basically the incisors are held and the posterior teeth are allowed to erupt as the vertical ramus height increases due to growth. So this is typically how arches are leveled in children and adolescents because there is growth. So the mechanism of action here is by eruption of the premolars, and the incisors will tend to procline a little bit. So if you look at this example, you've got a deep caruspi before treatment, you've got a full-sized arch wire placed pretty flat, and then reverse curves being applied to help flatten the caruspi. So this is great in situations where it can be applied. Now, there are situations where you want to be able to control the incisor inclination and the incisor position, and you want to minimally allow the buccal segments to erupt. In situations like that, you may want to consider absolute intrusion, where control of the line of action of the intrusive force is imperative. So in this example, you've got a one-piece intrusion arch, Burstone design, being applied in line, theoretically, with the center resistance of the lower incisors, and the posterior eruption extrusion is being controlled by a segment extending from the canine to the molar, which tends to dissipate. The forces tend to dissipate over that segment, which is why you're able to get your intrusion. You get about 0.5 to 1 millimeter per month is ideally optimal. So these are the two mechanisms as it pertains to leveling. Now, what happens with continuous arch leveling, which is what the majority of us use most of the time? So this was a two-part study, and different effects were seen depending on the nature of the malocclusion. So what Rossi and colleagues found is that with high-angle subjects, the molar is extruded, which is the last thing you want because that tends to rotate the mandible down and back. With low-angle subjects, on the other hand, the same mechanics tended to procline the lower incisors. Now, we often hear about subjects, people that talk about, hey, low angle, malocclusion, let's flare the incisors, which is fine, but is it stable? So in the second part of the study, what they found that relapse of overbite occurred in the low angle group because of incisor proclination tending to relapse. As the lower incisors uprighted, the overbite deepened. So you got both relapse of crowding and relapse of overbite here. So as it pertains to overbite stability, in general, overbite stability is pretty stable. However, a couple of things to remember is it's important to not overly procline lower incisors, especially in low angle cases, because more than 7 degrees or so, you would tend to expect some degree of uprighting or relapse. The other aspect, two aspects that Dr. Vic Alexander would allude to was it's important to fully level the mandibular arch in those deep bite cases and establish an optimal interincisal angle. So maxillary incisor torque, mandibular incisor inclination, and a fully level lower arch can certainly help establish overbite stability. So in this case, you see a pretty substantial curvus P before treatment, and here it is at the end of treatment. And this is certainly good, but it helps to go even beyond this and overcorrect to an extent to help ensure stability of the overbite. So now let's talk about sagittal correction or overjet. So with overjet, it kind of depends on where you start. Let's say you start with excess overjet. Obviously, you want to overcorrect that to where you bring them edge to edge, and let you do the opposite. Leave them with a little more overjet to account for some relapse or some growth. So ideally, obviously, you want to have about 2 to 3 millimeters of overjet and a light contact. And these are in cases that are normal, not excess in one way or the other. Overjet relapse, however, has been positively correlated with relapse of mandibular incisor crowding. So as the mandibular incisors crowd or relapse of crowding occurs, there can be relapses in both sagittal and vertical relationships. That means the overjet and the overbite can tend to relapse, which is why mandibular incisor crowding is correlated with so many aspects here. So here are a couple of examples. One of them shows you excess overjet. So in this case, you've got significant overjet. You've got a deep bite with the lower 3 to 3, which have erupted significantly relative to the occlusal plane, posterior occlusal plane. So this is the result at the end of treatment. You can see both the overjet and overbite have been corrected, and you've got an incisal stop that can help minimize the potential for relapse of the overbite because you've got a occlusal stop. Let's look at the other extreme. Now, in this case, you've got a class 3 situation, insufficient overjet. This case was attempted non-surgically by somebody and retreatment done surgically. So in a situation like this, you could finish with a little bit more overjet if you're concerned about additional mandibular growth. At this stage, he was 24 and unlikely to occur, so you can get closer to an ideal finish. So in terms of sagittal malocclusion, overcorrection is certainly something to consider. So let's talk about incisor position and inclination. In terms of stability, it's really the mandibular incisor position that we're concerned about because that's where muscular activity is predominant. So what we know from the work of Dr. Ackerman Profit, moving mandibular incisors more than 2 millimeters forward can lead to a sharp increase in lip pressure. So again, we have a bunch of opinions and some data on mandibular incisor, but we need to alter that for aesthetics, for function, for periodontal health, for whatever reason. So it's important to figure out in what direction movement, in what direction tends to be more stable. Based on that, what the data seems to indicate is uprighting procline incisors is important, as well as being able to maintain well-positioned incisors to within 3 to 5 degrees of their initial position. So again, this is work from Dr. Alexander, who had the room of truth in thousands of cases. And what he found is extraction or non-extraction. If you've got well-positioned incisors, it's important to maintain them to within about 3 degrees or so. So again, you have to look at where you start. If you're starting with incisors that are protrusive, they need to be uprighted. If you're starting with incisors that are well-positioned, they need to be maintained. if you're starting with incisors that are retrusive, they need to be optimized, which means you may need to consider advancing them. So, but you always have to kind of keep in mind the limits in terms of how far we can go. So now let's look at correction of root position. So this is something that gets overlooked to an extent, and especially in the mandibular arch. I'll give you a specific example dealing with lower lateral incisors, upper or lower, that are lingually displaced or blocked out. We see this very frequently, right? As you align them, the crowns tend to go forward, the roots tend to go further to the lingual. So what that means is the malocclusion at the level of the root is actually worsened during alignment. This is due to the moment of the force. It's important to completely get the root in line with the crown. So that means adequate labial root torque. Now, this is easy to see in the upper arch because you can see the gingival margin discrepancy. In the lower arch, it can be difficult to see. In this particular example, you've got two lateral incisors lingually blocked out. Towards the end of treatment, things look pretty good, but 18 months after treatment, you can see some degree of relapse here. And the reason that happened could be attributed to incomplete root correction of the lower lateral incisor, particularly this one. And even with a full-size wire, so in this case, the working wire was 1925 steel. You want to consider working up to a 2125 or whatever your slot size allows in the lower arch to make sure the roots are in the right plane, because to account for the slop or the wire bracket plane. Let's look at the example in the maxillary arch. So this we've seen before, we know. Aesthetically, we can tell. So you've got laterals that are lingually displaced. As you align them, you can see the change in the gingival contour. When you see this, you know that the roots are still too far to the palatal, but the brackets have been inverted. As the slot is filled, observe the change in the contour of the gingiva. And at the end of treatment, when the root is fully corrected, observe the difference between this to this. So you can see the change both at the level of the incisal edge as well as at the contour of the gingival margin. So it's important to ensure root correction there.
Was it from the 2125, Stanley, still in the end, or did you go to the 2125 wire?
On the upper?
On the upper.
Yes, I did.
Mm-hmm.
Yeah, I did. For two reasons, yes. One for root correction, but the other one was I needed to burn anchorage. Mm-hmm. So in that example, I did. And that's a good question from Dr. Ditmarov. The reason I say that is if you look at the final result, you can see the labial surface of the lateral. That means it's a little overcorrected. Now that can be attributed to using the largest cross-section of the wire. But that was not used necessarily for correction of the torque of the laterals. It was used to burn anchorage. But it can have that effect if you don't correct the orientation once the root of the lateral is fully corrected. So anytime you're going to use a full-size wire like that at the maxillary arch, you have to be careful when you've inverted the slot because the root can go too far to the labial. So in this case, some of that may actually happen.
Sorry, could I disturb you one more time? You spoke about torque and you spoke about root position. Can I ask you, what do you think about the angulation of the roots of the mandible incisors? Because according to Vic Alexander's finding, he said that it's more stable to have mesially tipped lower second incisors.
You're talking about distal root tip. Distal root tip as opposed to mesial root tip, correct?
Right.
100% agree with that.
Yeah, but
yes, absolutely.
In MBT prescription, we don't have this angulation.
No, we don't, but you can cheat your bracket a little bit to do it. Yeah. Or you can bend the wire. Yeah, no, I agree with what Dr. Alexander says, because there's a tendency for mesial drift over time. So roots that are positioned with lower incisor roots that are spread out and positioned with distal root tip are definitely more amenable to stability. And that's basically what I try to do as well. In general, if you look across the arch, every tooth in the arch is either upright or has distal root tip. Nothing has mesial root tip in any ideal prescription or what have you. But for the lower incisors, yes, I would definitely advocate distal root tip. So you can slightly position the bracket to get that. But yeah, certain prescriptions have that already built into it, like the Alexander prescription. But from the second order view, yes, absolutely. That is very, very important. But from the third order view, you've got to consider either inverting the slot in the upper or filling the slot in the lower, just to be able to get them in the same plane. So now let's look at root parallelism. So going back to Dr. Dittmer's point here, if you look at the beginning of treatment, you can see the lower incisor roots are a little bit convergent. At the end of treatment, you can see they're spread out a little better, especially the lower twos appears like they're either straight or with some distal root tip. So that is a good point. In general, root paralleling is critical between teeth on either side of the extraction site. And the reason that's important is otherwise things will tend to reopen, gaps will tend to reopen. So in this mid-treatment panoramic view, you can see there was a lack of parallelism, a couple of sites. At the end of treatment, things appear to be better and more parallel. So if you get roots more parallel to each other, less likelihood of extraction spaces reopening. So now let's look at posterior interdigitation or occlusal fit. So again, leveling out the arches, flattening the marginal ridges allow the teeth to fit together better and allows for better occlusal stability. So here it's important to draw the distinction between a class 1 and a class 2 molar finish. So in a class 2 molar finish, you have to remember to do two things. One is to rotate the maximolar mesial in, because that occupies a little bit more space, less chances of spaces reopening, and then it allows the teeth to occlude better. And the second aspect is neutralizing the second order, because most prescriptions have excess distal root tip in the upper arch, molar, to allow the distal buccal cusp to seat between the embrasures of the lower 6 and 7. But you have to neutralize that, because if you don't do that, that will be an interference, because basically the distal buccal cusp will seat, everything anterior to that will lift up. So in this particular example, I want you all to look at the differences between the second order angulation of this tooth, where you can see the distal buccal is slightly tipped down relative to the mesiobuccal or extruded. And here, where the distal buccal and mesiobuccal are in the same plane because of the difference in the class 1 versus the class 2 molar finish. But anterior to it, you can see the occlusion is remarkably the same. Everything fits together nicely. And this is an important aspect in terms of allowing for occlusal stability. So here are two examples. One of them shows you, actually both of them show the use of braided wire. So in this case, on the right-hand side, you can see there's a little bit of a lateral open bite. The concern here is a lack of potential lack of settling or stability. Things can tend to shift. So you really want to provide the interlocking effect, which was developed here by elastics. So at the end of treatment, you can see things are fitting together nicely. So you have some degree of control over the buccal segment stability here in terms of the occlusion. Another example here, you've got a little bit of a lateral open bite here, and the occlusion was developed with elastics for about 2 weeks, and things are seated together much better. So that again has a potential effect in terms of the long-term stabilities. So the quality of the finishing is an aspect that does affect stability, and specifically as it pertains to a couple of things. One is, like we discussed before, well-finished cases show less relapse as it pertains to extraction space relapse. Obviously, we know if you don't get the roots in the right spot, corrected fully, root parallelism, things can tend to, relapse, spaces will reopen. Occlusal relationships improve more for cases that have passed the ABO exam. That means that are better finished at DBON than for cases that failed. So even cases that failed the ABO can improve in certain areas, which is basically vertical relationships. That means, marginal ridges may tend to improve, occlusal contacts may improve. But rotations and alignment can worsen in subjects or cases that were finished worse, which makes sense. Cases that are not well finished will tend to shift, or the degree of change is going to make it worse compared to cases that finished better. Retainer design, important aspect as well. So in general, you want to transition to fixed retainers or Holly retainers. I don't recommend fixed retainers, but if you adjusted fixed retainers with a stiff wire can certainly do a fantastic job. Use of braided wire is not advisable because of all the literature we've seen on what happens with braided wire. So let's look at some examples of finished cases and post settling records. So these are all different time points. So this is a case you can see the buccal segment relationship here is not optimally seated, but over a period of 2 months, things tend to improve. And over time, you can expect the improvement to persist, provided the occlusal surface is not covered by acrylic, like with an Essex retainer. Essex retainers don't provide, obviously, that degree of settling because you've got acrylic covering everything. Another example, here you can see things have tightened up a little bit, about 6 months post-debond, and Holly retainer again. So in this case, you can see the stolarized, the molar is getting better stolarized here. Another example, the molar relationship and the premolar relationship on both sides improved a little bit with Holly retainers. Certainly the gingival inflammation reduced, which obviously can certainly help in terms of, making things look better.
Dr. Now, do you regularly have any clasps on your Holly retainers, or it's just a wrap around with a bow around all the teeth and no clasps at all?
No, I never use a wraparound, ever. And the reason is the wraparound has a lot of sag. So you could have a guiding wire of the wraparound that'll snap. The wraparounds just don't fit well. I really don't like them. And there's not enough retention with them because the distal wall of the 7 often lacks the height to allow a wraparound to fit. I use a ball clasp so both upper and lower retainers have labial acrylic. Upper retainers have a ball clasp between the 5 and the 6 in extraction cases, or between the 4 and 5 in non-extraction cases.
You do not like Adam clasps?
No, I do not like Adam's clasp because again, Adam's clasp tend to be exceedingly retentive in some cases, so they can get distorted sometimes. They make it difficult to seat. You want something that goes in relatively easy, and the ball clasp, when well designed, works amazingly well. In the lower retainer, no clasps at all. All we have is an occlusal rest. So with the lower retainer, the lingual shelf of the mandible has got the retention because you've got that retainer that extends down, so that height provides the degree of retention you need, but you need to have a stop to make sure it doesn't sink completely. So occlusal rest helps. And again, these retainers are very unobtrusive and easy to use because the more difficult it gets to use, the less likely patients are going to want to continue using it, So, so that's kind of what I use. So here's another example. Now, in this case, the settling was very limited because this was in Essex, and this is 18 months post-treatment. You don't see much change, which is, again, because of the Essex. And here's one 19 months post-debond. Now, in this case, you can see things seated nicely, but there obviously was some deepening of the bite. So what this tells you, again, is you want to consider overcorrection of vertical malocclusions because of the tendency to move in the direction of the original malocclusion. And here's another case, 26 months post-debond. Things are settled well on the right and left-hand side, and will continue to improve over time. So now let's look at some soft tissue considerations. So we know that soft tissues are really paramount when it comes down to the pressures exerted by the lips, cheek, and tongue, because that influences the position of the dentition. The periodontal apparatus, again, influences the position of the teeth, more so with rotations. We already discussed how the periodontal tissues, the transseptal fibers, can influence relapse. Muscles and connective tissue of the TMJ also play a role. So if you can, orthopedic stability is an important aspect as well. So if you've got balancing interferences, or you've got occlusal interferences that produce a large centric CRCO slide, you can end up with issues there from that perspective. So you want to have harmonious functioning of this dentition relative to the soft tissues. The limit of movement is frequently established by the soft tissues as well, that ultimately eventually determine how far teeth can be moved. So obviously this is much more relevant when it comes down to equilibrium, because this is referred to differently. Equilibrium, the neutral zone, Tom Mulligan would call it the neutral zone. Now, where the zone specifically is a different issue. We know that there is a zone, but the specific location of it or those kind of things are tougher to establish. So it kind of helps to have some guidelines for how much can be moved, what is likely to be more stable. So in general, we know that the pre-treatment position of the teeth reflects soft tissue influences already to that point. So up to a certain point, this is the harmonious position of the teeth. But they may present with crowding or protrusion. We need to address that. So the question is, how much can we move these teeth and how stable will the result be? So from that perspective, it helps to know the magnitude and direction. So with regards to the direction, what we know is that retracting, protruding incisors is unlikely to be unstable. That means it is pretty stable to retract incisors, unless you're dealing with a tongue that's excessively large. But proclining lower incisors may not yield a stable result. So from this, what one can infer is that the tongue may be more forgiving than the lips, because what we see is that advancing incisors tends to be less stable, retracting incisors tends to be relatively more stable compared to proclining them. So this was a graphic from classic paper by Ackerman and Profit. If you'll note in this image, there's different numbers for how much you can stable expansion across the arch. If you look at the canines, you pretty much see 0. That means any degree of expansion there tends to be unstable. So what this tells us is basically 2 millimeters. You can advance incisors about 2 millimeters after which things can be unstable. Lateral expansion of about 2 millimeters per side, and then things are less stable. So this is generally a useful guideline to consider in terms of what we're hoping to do and the odds of stability. So when we're looking at these things, we also want to be conservative in terms of we don't want to push things to the outer limit of stability, because that wouldn't make a whole lot of sense. So perioral strain is an indicator of incisors that are protrusive relative to the lips. And all of a sudden, you've got a lip muscle that's more active than it normally would be. So these two examples, you can see perioral and mentalis strain. Example 1 before treatment, after treatment, more harmonious soft tissue drape. Same here, you can see some perioral strain, mentalis strain before, less so at the end of treatment. So from the perspective of muscle equilibrium, one might expect better stability in terms of the muscle lip tooth relationship at the end of treatment here and at the end of treatment here than where we started. Because again, one argument is, yes, the stability there is as good as it is because that's the pre-treatment position. They're relatively stable, but we don't know how stable they'll be over time. So that's the other thing that one is not aware of with these subjects, because if you've constantly got that mentalis pressure over time, you may expect to see some degree of change. So now let's move on to our clinical examples. So with these, each one of these examples, we're going to discuss some stability concerns and then see if they were addressed. So first example is one of a skeletal transverse discrepancy. So here you have an intraoral image of a subject that has a unilateral crossbite. You've got an excessive curve of Wilson. The lower buccal segments are excessively lingually inclined. The upper arch is showing you signs of compensation. You can see the palatal cuts are hanging down a little bit. From the cephalometric perspective, the lower incisors are a little protrusive. There's a little bit of mentalis strain. Let's look at the rest of the data. So here's a subject who's about 12 years old. You can see the maxillary arch is constricted. The mandibular arch is also constricted with some degrees of compensation evident here, you can see. And you've got a unilateral crossbite. Things are not fitting very well. So what are our stability considerations for her case? You also see a canine that's not fully erupted on both sides. Here, the considerations would include controlling the maxillary transfers and avoiding archwide expansion. So we want to address the transverse relationship without placing the dentition in unstable positions, which archwide expansion can do. Hold the maxillary canines after correction to avoid reintrusion, because once the canines erupt, or if they're extruded, we want to make sure they don't re-intrude. And to do that, you've got to make sure you control or hold them for long enough. Adequately correct the curve of Wilson to allow for interdigitation, occlusal stability, and make sure the roots are centered, to remove the transverse compensations, and to retract the lower incisors to improve the mentalis strain. So in her case, the mentalis strain was slight, but it was still present here. The lower incisor is a little bit protrusive, lower lip is manifesting some of that. So let's look at the specific execution of treatment. So here is the transverse correction stage. She was about 12, so sutural expansion was possible. And you can see the canines are beginning to erupt. At this stage, the arches are relatively aligned. And here we are following space closure. So in her case, the upper and lower second premolars were extracted. And this is after the spaces are closed. At this point in time, you can see the second molars are erupting. There's probably enough room to get on them. Here, the second molars have been banded. So there is some soft tissue disharmony in the anterior. We do have some altered passive eruption with some gingival inflammation. So she was referred to the periodontist for aesthetic crown lengthening. This is her a few weeks after. And you can see that the gingiva is still inflamed, but the clinical crown heights and the width to height ratio certainly improved. So when you look at her soft tissue profile here, things are a little more harmonious. And in terms of the occlusion, we've got to get a little bit more overbite in the anterior because the bite's a little open. So let's look at the finished result. And here is the finished result. So if you look at the finished result, I know it appears like she has a cant, but she does not. She actually animates asymmetrically, unfortunately, a little more on the left-hand side than the right-hand side. But if you look at the alignment of the lower incisors, they appear to be pretty good alignment. The spaces are closed. The curve of Wilson has been corrected. If you look at the upper buccal segments, they are not tilted to the buccal. And that would happen if you tried to expand the arch with just arch wires. So that can lead to obviously dental instability, but also occlusal instability. And if you look at the occlusion, it seems to be well seated and can improve over time with the right type of retainer. So let's look at the close-up image here. Again, you can see the close-up. So if you look at this view again, you see that the maxillary buccal segments are not excessively tilted towards the cheeks. And the panoramic view, you can see root paddling is pretty reasonable. Things, lower incisor roots are well spread out, like Dr. Dittmer was saying. And the cephalometric view shows the cranial base and the regional superimposition. So if you look at the cranial base superimposition, you can see that the lower lip was slightly retracted. The soft tissue and hard tissue chin moved anteriorly, and there was some vertical change as well. So in other words, the hold-away ratio improved, and the regional superimposition can tell you why that happened. So it's a combination of some incisor retraction, which you can see at the regional superimposition, and some mandibular growth. So both aspects help to improve the lip-tooth relationship, both from the perspective of aesthetics as well as from the perspective of stability, because you no longer have the potential for lip strain in that region. So now let's evaluate post-treatment analysis. So based on what occurred here, the transverse was adequately corrected because the choice of treatment plan here included patternal expansion with an expander, and the curve of Wilson was optimized in both arches. Lower incisor retraction helped improve the lip-chin relationship and reduce mentalis strain. So now let's look at our last case. So this is a different example, class 2 div 2 with an impinging deep bite. So this subject comes in with basically upper incisors almost completely covering the lower incisors. Buccal segments are class 2. You've got the typical div 2 excessively upright, detorqued maxillary incisors that are 97. And then you've got basically the retrusive mandible, A and B is almost 8. And lower incisors are 95, which is, probably a little more upright for a low angle malocclusion than you would expect to normally see. So now let's look at the entire record. So here you see you got class 2 buccal segments. The left side is almost full cusp class 2. Maxillary arch appears to be a little narrow. You've got maxillary incisors that are over erupted. You've got a significant curvus P. You've got some crowding here. and some posterior crowding. If you look at the lower left-hand side, you don't see the second molar there. So let's look at some of the stability considerations in this case. So here we've got some aspects that we need to consider. This is a vertical low angle malocclusion, so it's important to level the arches and open the bite and fully flatten the lower crus peak, because that'll help minimize the potential for vertical relapse over time. Helps to establish adequate maxillary incisor torque, because the maxillary incisors were 80 or 90 degrees, and we've got to get the torque corrected in order to maintain overbite correction, and also establish a good interincisal angle. Improve the lower incisor inclination, because in her case, the lower incisors were probably a little bit upright, given that it's a class 2 div 2 malocclusion. It's very reasonable to leave them where they are, but we're talking about overbite stability here. So from that perspective, you may want to consider advancing the crown slightly and moving the root to the lingual to alter the inclination of the lower incisors. So let's look at the actual execution of treatment and see what happened. So here we are at the stage of initial alignment. So again, you have to keep in mind the transverse relationship, and not just the dental, but the skeletal transverse relationship. These are subjects we're treating to a class 1 relationship. So all of a sudden you've got the mandibular arch occluding with a narrower portion of the maxillary arch. So you have to consider addressing the transverse from that perspective. So RPE was done to expand the maxilla, and the arches are being aligned at this stage to open up the bite, because in these subjects, until the bite's opened up, you can't consider retracting because the bite's too deep and you don't have enough space. So at this stage, where extractions have been done, upper 4s and lower 5s, the canines have been retracted into class 1 or super class 1 on the other side with class 2 elastics, and the maxillary space closure has now begun with sliding mechanics. Class 2 elastics were still being worn at night. So the right side looks much better in terms of the molar relationship. Left side still has some work in terms of correcting the molar relationship fully. So now let's look at some progress records. So at this stage, the canines were retracted. The incisors are being retracted with the closing looped arch wire, 1925 TMA to retract the maxillary incisors. Class 2 elastics still being worn at night. And here, the second molars were banded. Now, I want you to look at the second molar on the right-hand side. So when you see that degree of deflection, that means there was a significant amount of posterior crowding in the upper arch as well, because there's not enough room for the second molars to erupt. So now, anytime you have a situation like this, as the second molars are getting aligned, the occlusion is going to go through various changes. You can see things begin to worsen significantly as the second molars are getting aligned. That may occur because of extrusion. It may occur because of torque correction. So it's important to fully correct the second molars to make sure you don't have balancing interferences on those teeth. And here is the next stage. We're in 1925 steel, and you can see the degree of deflection of the wire. So that's both vertical and in the third order. It needs a significant amount of torque correction there. So in cases like this, the tubes need to be converted. You need to place bends in the wire, add torque, step up the 7s to make sure they're not precluding things from occluding, because that can present an interference there. So we still need some buccal segment correction on the left-hand side. So here we are. The 7s are in a better position. At this stage, I think we switched to a round wire on the top and running class 2 elastics to get everything to fit. And we're another stage of incisor retraction to retract the maxillary incisors. Buccal segments are looking better. And here is the braided wire stage towards finishing. At this stage, you've got a pretty good occlusion developed on the right-hand side. Midlines are almost on. Left-hand side still needs a little bit more correction, which is where the braided wire helps, because it allows teeth to move a little more freely. Class 2 elastics are being applied on the left-hand side. So here's the final result. If you look at the final result, you can see that extraction spaces are closed. The right side occlusion looks pretty good. Left side's improved, could be a little better. Midlines are fairly coincident, and the crus P has been fully leveled. and the bite has been opened up adequately. So let us look at some of the additional records. So again, this is a case that started off with an A and B of 8. So a surgical plan here would have been a very reasonable consideration and was actually discussed. So her older sister had orthognathic surgery. I, treated her, and parents saw the result and they didn't think it was that much of a difference. So we discussed and felt like we could get a reasonable non-surgical result, which is how we proceeded. But the gold standard obviously would have been orthognathic surgery. So if you look at the finished result, you can see that the lower incisors inclination changed about 6 degrees or so. But it's important to look at the superimposition to see what nature of tooth movement led to that. So let's look at the superimposition. And here you can see in the cranial base superimposition, there wasn't hardly any anterior growth. There was some vertical growth of the mandible. In terms of the regional superimposition, you can see the change in inclination or the root torque. Basically, the net movement was the root moving significantly, maxillary incisor root moving significantly to the palatal. The lower arch, you can see that the lower incisor proclined. There was a little bit of movement of the crown and the root went lingual. And in terms of vertical, looks like the maxillary molar erupted as a result of the vertical ramus growth that occurred. So let's put this in context of our stability goals once we look at the pano. So in the pano, you can see the degree of root correction we had between the lower right 2 and 3. The lower 3 needed to move erupt significantly. And if you look at the root paralleling, that appears to be fairly reasonable in the maxillary mandibular arch. So from that perspective, the extraction space closure expectation for that will be reasonably stable. So the post-treatment analysis in this case, as it pertains to the vertical components, show that the arches were fully leveled with a flat curve speed, adequate maxillary incisor torque, and a good interincisal angle. So as a final aspect of stability, a Hawley with a bite plate can help control the vertical during retention. In her particular case, I wouldn't be too concerned about it, but in other cases where the curve of speed leveling wasn't as great, one can certainly consider using a Hawley with a bite plate because that can certainly help ensure minimal vertical changes over time. So now, with that said, let's summarize. In general, it's important to remember.
Dr. Raj, do you think that Hawley with a bite plate could just stabilize the overbite, or could it be an active appliance and intrude the lower incisors a bit?
That is a good question. So it kind of depends on how much you're using it and how much force is being brought up to bear against it. So you've got folks that sleep with it. Let's say you're sleeping with it at night and you have a history of clenching or grinding. Then you'd expect to see some inclination change as well. The lower incisors would tend to procline. Intrusion, not so much as proclination, yes. But if it's just passively there, any change that occurs during the night will tend to relapse during the day. But you could certainly have, if there's growth remaining, it could certainly allow the posterior teeth to erupt, you see? And I mean, that could occur normally as well because there's vertical growth remaining. And that can help with regards to maintaining your curve of speed. So it can act as a passive appliance, but still help hold things. But if you're seeing some degree of proclination, that's likely related to habits. Somebody's clenching or grinding too hard on it. So that would not be a good thing. So does it answer your question?
Yes, thank you.
Yeah. So when we look at the dentition, we need to consider positioning it within the limits of the hard and soft tissues, because that would really be what helps long-term stability. Excessive incisor proclination or expansion of the intercanine width, and we've known this for years, for decades, that obviously should be avoided. And it's possible to avoid it and still obtain very, very good results. Overcorrection of rotations, sagittal and vertical relationships should be a serious consideration. And, we're all guilty of it. We forget towards the end of treatment, which is why we want to consider doing this right at the beginning of treatment. So in other words, maybe have your brackets positioned to help with overcorrection. That way, towards the end, you're already set. So with that, I would like to conclude. Unfortunately, unfortunately, over the years, orthodontics has devolved into an alignment-only specialty, and it is far more than that. We have the ability to influence facial balance, stability, dental aesthetics, and that's basically what we need to focus on, and not just alignment, because then we're no different from Smile Direct Club. Treatment goals that include post-treatment stability withstand the test of time and can make all the difference between an acceptable versus an excellent result. So like the saying goes, if you aim at nothing, you'll hit it every time. So your choice of treatment plan and biomechanics needs to be consistent with concepts of long-term stability, because we have mounds of information on this. All we need to do is pay attention to it. So long-term stability reflects excellence in orthodontics, and those who strive for that will always stay close to the concepts of orthodontic excellence. With that, I would like to conclude my lecture, and I would like to thank Dr. Ditmaro and Dr. Yakub and the study club for your attention and participation. Thank you so much.
Thank you, Dr. Raj, for your informative lecture. And if you don't mind, we have a few questions from the audience.
Sure, absolutely. Go for it.
So anyone want to ask any questions? Can we turn the light on, please?
We have one question from
Facebook.
yeah, Facebook.
Uh-huh.
From Breen, she said, amazing lecture, Dr. Vishnu. Would you please elaborate more on this topic? Why MARPI is more stable than SARPI? Thanks a lot.
That is a good question. And again, I think Dr. Sylvain Chamberlain has some data on this. The question is why MARPI is more stable. The answer to that is I really don't know the answer about why, but from the data on it, because this is not that well publicized, but because we don't really have a ton of data yet on MARPI. We do have some, but I do remember reading something that either is about to be published or going to be published by Dr. Sylvain Chamberlain. I can only speculate as to why, but it may have to do with the fact that the procedure of the SARPI has some degree of surgical relapse associated with it. Whereas with MARPI, especially with a purely bone-borne appliance, you don't have the surgical relapse. Obviously, there's no surgery, and you have minimal dental relapse because it's not connected to the dentition. That's the only thing I can speculate on. So with the SARPI, you still have some degree of dental relapse because it's connected to the teeth as well. And you do have some degree of surgical change because there are some surgical cuts and there may be some degree of change at the surgical sites. But that's purely speculative. I don't really know the answer to that. But I think Sylvain Chamberlain has done some work on this, and he'd be a good person to ask.
So, anyone, any more questions?
Dr. Yes. Do you use in extraction cases for upper molars? Do you use lower tubes from the opposite side?
Help me understand what's the rationale for that? For root paddling, or what are we trying to do?
No, it has no I guess. To put the molar more mesially rotated, or you just position your,
no. Yeah, no, I just position the, if I use tubes,
yes.
I'll position the tube, a little more to the distal, but majority of the time I use bands. So I will just place a bend in the wire if needed. But yeah, I mean, there's many ways to do it. You can, whatever works. So for me, the simplest thing is usually to bend the wire, but if it looks like it needs a little more correction, then I'm going to remove the band and place a tube, but I'm going to position a little more to the distal, so I get the rotation distal, mesial in, distal out rotation.
Okay, thank you.
Can I please ask you,
problem.
what's your
Sure.
for RME? Let's say for the cases you showed. how often did you turn the jack screw, and yeah, how many times per day?
So typically I do 2 turns a day for 10 days and then evaluate to see if additional expansion is needed. So several subjects, and again, it's important to overcorrect. So I'll expand till the upper palatal cusps contact to the lower buccal cusps, and 2 turns a day for 10 days, and then may go again another 10 days after that. So depending on the situation, between 20 to 40 turns, maybe more, and then consolidate and hold that. But I hold it for a very, very long time. So because the retainer design I use is not really amenable to control transverse relapse. So really, I want the transfers to be stable at the end of treatment.
Do you think that heat-treated wires could help with stabilizing the transverse expansion, let's say, with RME? To some degree.
Not some maybe, but more importantly, it can help stabilize the intercanine width. Absolutely. Because with regular wires, you can see they get distorted. It's not so much you're deliberately expanding them, they get distorted, especially if the staff are taking them in and out. And several times the arch form, when you go back to put it in, it doesn't even look human anymore. I mean, it looks like, a Doberman's arch form, or it looks just like a hugely expanded. Yeah. So that can happen if the wire is not rigid enough. So it's important to pay attention to that. Always check your arch wires to make sure they look like they're supposed to look like. Because if you got something that looks excessively tapering or excessively broad, that's not normal. In general, you don't see arches like that. So that's one of the things that the heat-treated wires do. They tend to hold the arch form a lot better. So you don't have inadvertent expansion happening when you're removing and putting the wire back in.
Okay, thank you. So any more questions? One more question from any group.
My question, in cases of extraction of upper fours and lower fives, when would you recommend, or when would you usually include or ban the sevens, and when would you bond them early on?
So it also depends on if you have a deep bite and how successful you are in opening the bite. So a couple of things, generally get on them as convenient as you can for banding, that is. So in the previous example that we were looking at, the sevens hadn't erupted enough to permit bands on them. So you could certainly put tubes on them if you're concerned, but the problem with that is they can certainly pop it off. It can lead to, if your tubes are malpositioned, that can lead to some issues with regards to the sevens being, in the wrong spot. But in general, if you got a deep bite, you want to start getting on the lower sevens earlier than, than you normally would. But it also comes down to how quickly you can get on them. So I've had situations where I'll get on them in the first 6 months, then I'll have situations where I'll get on them almost at the month 20 or month 22. But at the end of treatment, by the time treatment is finished, I want to have both sevens aligned, upper and lower sevens, which means bands on upper and lower sevens. So really, from my perspective, it's one of access and convenience. With the 22 slot appliance and wires that are stiff enough, you can still open the bite, pretty conveniently without including the sevens. But obviously, once you get on the sevens, it really helps open up the bite. No question about it.
So thank you so very much, Dr. Raj. We learned
No problem
today, and thanks everyone who joined us online. And with this being said, we are concluding our online live stream today. So
thank you so much, everybody. Thank you, Alex. Thank you, Danny. And thanks to the group. Take care.